ACNS ISMIN webinar. So our topic today will be presented by seven speakers based on the program. I think 8 speakers, sorry. So we have about 2 hours between 5 to maybe 7 to 8 o'clock. It is 5 o'clock in Japan. Am I right?
Yes.
Okay, it's about 4 o'clock in Malaysia. I think 1 hour apart. So we have I've seen a lot of senior people from ACNS as well as ISMIN in the group. So first of all, we would like to invite Professor Yoko Kato to start with the opening speech. Professor Yoko Kato.
Okay, thank you. Thank you, Azmi. So very nice to see you, Azmi. Long time no see. So it's a great pleasure to welcome the seven, the great speakers today. I think now is the time of the minimally invasive treatment. All speakers are very good at such kind of the field. So, but we need the more one step advance is extreme minimally invasive. We wish to listen from all the speakers. Thank you so much.
Thank you, Professor Yoko Kato. So if no further ado, I would like to invite the first speaker, Professor Junichi Mizuno. He will talk about interspinous device for lumbar spinal stenosis. Professor Mizuno?
Yes, do you hear me?
Yeah, very clear.
And how about my presentation to everybody? And I'm a Dr. Mizuno. I'm a neurosurgeon as well as a spine guy. So today's my topic is dynamic fixation for symptomatic lumbar spinal stenosis by using interspinous process device technique. I'm from 𝐸𝑖𝑟𝑜𝑘𝑖 General Hospital, and which locates in Kanagawa, Kawasaki, Japan. I have nothing special for disclosure. So this is one of the representative case, and actually the first case for me to use this technique, 78-year-old Japanese male complaining of severe back pain. Actually, he had 2-week history of worsening back pain, which was so against to the conservative treatment. So at the end of 2 weeks, he couldn't stand up, nor he couldn't walk for a moment. When he had in flexion position, his back pain slightly improved. And I have decided to use this IPD technique for this patient. And immediately after that, he showed the great improvement of back pain. He was almost pain-free situation, and he could discharge from hospital post of day 5. So thinking of the pathology of lumbar canal stenosis, there are 3 components. One is bony canal stenosis, as well as you know, included congenital canal stenosis. The second one is, I believe, most common cause for canal stenosis, that is a hypertrophy yellow ligament, which is included in soft tissue canal stenosis. And the number 3 is today's topic, dynamic canal stenosis. When the patient has a hyperextension motion, the back pain increase. So today's talk is targeting this number 3, dynamic canal stenosis, how we can treat this. So today's agenda is extremely MIN treatment. What is the best harmless treatment? So as for treatment of spine, laminectomy is historically the well-accepted treatment. I think everybody agrees this. And then laminectomy or fusion is invasive procedure, but in the point of prevention of spinal motion without bony insert or without joint inserts, interspinous process device can be the best harmless method. This is a short history of lumbar dynamic fixation, and Wall system was used as IPD in Europe. And purpose of IPD is to prevent hyperextension position of the back to reduce back pain. So there are many types of IPD are now in the market, and I think the complex system was most used all over the world. And materials of IPD are either titanium or PEEK. What is about the benefits of IPD? It's truly minimally invasive spinal surgery and just prevent the hyperextension position. And this technique can preserve the lumbar motion, flexion, lateral bending, as well as twisting. And hope that this can also contribute a possible indirect decompression by reducing enfolding of the hypertrophy ligament. That is the number 2 causes for lumbar canal stenosis. And this is very simple technique and short operate time, and this is minimally invasive so that patient can discharge from the hospital in short days. And we don't need to worry about the post-op hematoma because this is outside of the bony structures. And this can preserve the spine as well as the facet joints. This is one of the academic papers from the United States in 2021, and it's mentioning that this IPD can be considered to be one of the minimally invasive techniques and methods for the back pain caused by the canal stenosis. So this is as good as the result of IPD is as good as laminectomy or laminectomy and fusion. So when I was young, I visited these guys in San Francisco at St. Mary's Hospital to learn the IPD technique. At that time, this implant is what's called the Stennex X-stop, extension stop. That is a original idea for mechanism. And these are some representative implants in this technique, including Stennex, Coflex, and so forth. So Swift is relatively a new IPD implant made in Japan. And this is quite similar to Sten-X or X-stop. But this was introduced to us in 2021. And this is a very simple procedure, and we don't need to worry about any serious complications from this technique. This is a starter this is a case of L3 for canal stenosis. This is a starter. We need a 3 centimeter skin incision. It's a very small skin incision. And bilateral ligament dissection for insertion of this. And this is a wing of Swift system. Just to place this implant, small implant between the spinal processes. Usually we use 6 centimeter or 6 millimeter or 7 millimeter inserts for Asian patients. So what about the benefits of IPD? Again, as you may know that this can preserve the supraspinous ligament, which is very important to stabilize the spine. And also, at the same time, this can preserve almost all parts of interspinous ligament, which contribute the spine stabilization. And also preserve the deep layer of the paraspinous muscles and no invasion laminar facet joint. So this is not a quite new implant, but the evaluation of IPD includes back pains, as you know, most common complaints, and treated by many physicians and surgeons. And the major operations are considered with a decompression fixation, but these are the violating procedure. So that these techniques are not may not indicate for poor risk patient and high age patient. They need more safer operations. So what about the indications? Most favorable indications back pain or leg pain and subside inflection and enhanced in extension. The target levels are from L5 down to L5, L1 down to L5. So patient must be over 70. That is ideal. Don't use these implants younger than 70s. So symptoms are back pain and side pain without bladder or rectal symptoms. In MRI, it's mild to moderate lumbar spinal stress. Don't use this implant to the MRI with severe sleeping or severe stenosis. Control indications IPD, association hernia disc, and over the grade 2 spondylolisthesis with instability, severe canal stenosis on MRI, and severe canal stenosis causing walking disability, bladder or rectal dysfunction. I think that everybody can accept these contraindications. And operating method, what about the anesthesias? It's up to the patient, no, it's up to the doctor's preference, general or local anesthesia. In the prone position with maximal flexion, and small incision is good with C-arm, and small incision with bilateral fascia, and just insert the Swift IPD system with C-arm. You don't need to worry about post-op hematoma. This is the operating theater patient prone position with maximal flexion. And true AP and true lateral position is necessary. This is just a 3 centimeter skin incision. The bilateral fascia is dissected. This is a case of L34 and L45, and this is a starter. And then with this is the dilators. In this case, patient had just a local anesthesia. We could control the patient very nicely. And this is serial dilator, so from I guess 5 millimeter to 7 millimeter. This is a Swift system. We place this Swift system between the spinous process, and then after insert this body portion of the Swift system, and then we insert the wing portion. This is a wing. And we tighten up the wing to the body. That's very easy and quick. But that's it. I believe that everybody can do it without any difficulty. This is a one-level operation. You see through the system here and here, and then this is a two-level. Sorry, this is just Japanese. This is a leg pain, pre-op and post-op, and this is a back pain, and this is the number of the drugs from two, three kinds of drugs down to 0.8, and this is a JOA score. This is a intermittent claudication. This is a Swift, 8 millimeter, and lateral distance is 16 millimeter, and height, this is most important, from 6 to 10 millimeter. And this is the tools for Swift. Only 5 different tools, but that it's very small and compact. So in summary, so good indication for high-age patient as well as a high-risk patient because of a small invasion. So indication is the most important for success of these simple and minimal invasive operations. So mechanism for relief pain is dynamic stabilization, preventing extension. Well, I thank you very much.
Thank you very much, Prof. Zono,
Thank
for
you.
speaking on time. So because of limitation, we will limit one presenter between 15 to 20 minutes. So I have only one question. So how long
Yes,
it
sir.
takes? Yeah, how long it takes for you to insert the implant, and what is the maximum numbers of implant that you can do?
As the maximum number of the implants for one patient is two. Don't use more than 2 implants for the one patient. And I started this technique in 2021 for more than 3 years. So far as in my experience, I don't have any serious complications and overall good result. It's really minimally invasive technique in spinal session. Thank you.
Thank you very much, Professor No. Thank you very much for your very nice presentation.
Thank you very much.
Thank you very much. So we move to the second presenter, Dr. Mirza Pjovskiks, on robotic guided MIS spine surgery. Do we have
Morning.
Dr. Mirza? Morning. Okay.
So, can you see the presentation?
Yes. Can you
Yes.
play a presentation mode? Okay, perfect.
Good morning, dear Professor Kato, dear faculty, dear Boom, thank you very much for the kind invitation. My name is Mirza Pjovskiks. I'm assistant professor at University in Marburg and senior staff surgeon at University Hospital in Marburg, a department of neurosurgery. Marburg is a small city, some 100K north of Frankfurt, but it has a large university hospital. And our chief professor and chairman, Professor Rimsky, is very famous for introduction of modern technologies in neurosurgery. So that's my background, and this is why I've have a lot of contact in my career with robotics and with microscope-based augmented reality. I'm going to talk about percutaneous pedicle screw implantation in the context of robotic spine surgery. So the first percutaneous insertion procedure was in 1982 by Maguire, and the first commercial system was introduced by Dr. Kevin Foley in 2001. That was in the context of MIS TLIF, and that was the first generation of commercially available system. I had a pleasure to conduct a fellowship in Memphis some 7 years ago, and also to be the department where Dr. Foley is working. So I've seen this first system and all other systems which were then developed, and they've kind of changed the whole concept of spine surgery, because now it is possible to insert screws and insert even cages via very small corridors. And in that way, you spare the muscles, the fat, the skin incision, and you can use it for various indications: degenerative, oncological, traumatic, and infection. So when we talk about robots, it's a very current subject. It's everywhere, from toys until the new AI models made by Elon Musk or made by Chinese. And there's always a discrepancy between imagination and reality, because we always imagine robots to be them like in the picture on the right side, like androids, which can really help us during the surgery. But the truth is that the most advanced robot still is Mars Rover 1, so just a vehicle which drives around Mars. And there are several types of robots. And the robot which we use mostly in neurosurgery is a shared control system, where robot and surgeon remain in control. Surgeon remains in control of the procedure, while the robot provides steady hand manipulation of the instrument. And in spine surgery, current FDA and EMA approved use is only for assisted pedicle screw placement, i.e. placement of K-wires. It's important because screw misplacement can occur up to 8.7% of the time. It can lead to clinically relevant symptoms in up to 1/5 of patients. It's been around for some 20 years. These are many robotic systems which we have nowadays for implementation of screws, and the pros of this technique are operative time, because you then need less time for a reduction of wound deficit and wound healing deficit, very high pedicle screw placement accuracy, and decrease in revision rates. Cons are paradoxically also longer operative time, because there are registration and installation issues, and there is a plateau of the learning curve. So in the one moment when you've achieved the learning curve, there is no further improvement. We have now age of active robots for pedicle screw placement. This is our first experience with the 𝐸𝑟𝑜𝑘𝑖 robot from Robotic Arm from BrainLab. And these robots are capable of automatically aligning to the pre-planned screw trajectory. So this is the setting from our OR. This is the robotic arm. This is the placement of the surgeon, of the scrub nurse, and of the intraoperative CT. And our workflow ends preoperative imaging. We do the screw planning of the preoperative imaging. There is an AI module which can count the vertebrae and which can give you a proposal how to put screws. Then we do the intraoperative imaging with automatic registration. We fuse the preoperative imaging with intraoperative CT and review the pre-planned screw trajectories. Then we perform the robotic-assisted insertion of K-wires, which is followed by fluoroscopy-assisted insertion of pedicle screws, and then a further control ICT. So this is the setting. Here is the patient. It is a CT in the OR. And this is the reference area which we use for navigation. And this reference area is attached at the spinal process of the vertebra. Still, there are very risk factors for screw misplacement, and they are with robotics only slightly better compared to navigation. We have a low entry point, registration inaccuracy, movement of the registration array, osteoporosis and skiving, abnormally steep slope, obesity, and congenital scoliosis. And this is the case which we have published with the misplaced screws with a robotic technique. And we think that this happened because the registration array moved and because the system has shown us that the screw is in the right position, but it's not. Pedicle screw time is one important quality, and when you look at the literature, for one screw with robot you need 3 to 4 minutes. In our experience, in our robot, which I'm not going to publish because we've performed over 100 surgeries, probably the department with most or Europe with specific robotic arm, we now need 4 minutes to put a screw with this technique. So cervical, and there are some cases on robotic assistance for minimally invasive placement of cervical pedicle screws, and there are also this where there are 3-dimensional measurements of ideal trajectories. And the thing is that there are many anatomical taking care of when you want to put a cervical pedicle screws, because a major breach occurs in cadaver series in about roughly 1/3 of the patients, and one major breach in cervical spine is very dangerous because it can lead either to the injury of the vertebral artery or to the injury of the spinal cord. So this is one case from our department, patient which had a fall down and fracture and a massive stenosis of the spinal canal. So this would be the operative setting. We place the head in the Mayfield clamp, and we attach the reference array only in this case, not to the spinal process of the spine, but to the Mayfield clamp. And this is the position of the robotic arm. And the principle is you plan the trajectory, you bring the robotic arm over the pre-planned, over the projection of the entry point of the pre-planned, the robotic arm or the kinematic unit, the head of the robotic arm, aligns automatically according to that screw trajectory. And then you use the robotic arm as a drill guide, actually, as a very steady instrument in order to drill the canal in the pedicle and to place a K-wire, and then over the K-wire to place the navigated screw. So this is the screenshot from the OR. This is the position of the instrument holder, of the instrument holder through which you put the drill guide. And this is in the end the implantation of the navigated screw, which shows a very, very less deviation compared to the pre-planned screw. And we perform then the intraoperative CT during the surgery, and in that way we have the immediate quality. And these were some follow-up images of this cervical screw. In a thoracolumbar spine, we also perform a lot of percutaneous implantation of screws, and this would be one classical setting. So you can either put small incisions laterally from the spine and insert the screws via these small incisions. But we prefer now to open up the skin in the middle to do the preparation of the fascia, and then we up to the fascia, and then we do not open the fascia. We don't do the subperiosteal preparation, but we then go through the muscles in a minimally invasive fashion. So this is the robotic arm. You bring it over the projection of the entry. The robotic arm aligns automatically to the pre-planned screw trajectory. You go with the trocar and with the instrument holder directly on the skin through the fascia on the bone, and then through this instrument holder you do the drilling, put K-wire, do the navigated screw, and then in minimally invasive technique with dilators you put a screw which is attached with a tower. And this would be the technique. First the dilation, and following the dilation, then you go with the screw over the K-wire. And there is also then a technique how to place the rod under the fascia in the heads of the screws, and then to do the locking of the screws. So percutaneous procedures is not in all terms superior to the open. It has a higher overall violation grade and greater incidence of high-grade violation of superior level facet joints compared to open procedure. These are some cases from our department: a fracture which was conducted with stabilization and implantation of the expandable cage, or this case of spondylodiscitis. And I have a small video which I would like to show as an addition, but I cannot put it from my presentation. This is our department. These are some photos of Marburg. We are now doing a textbook for Springer as editors, my boss and myself, on clinical applications of modern technologies in neurosurgery and spine surgery. It's expected to go out in spring 2026, and I invite all colleagues who are exposed to the modern technologies and who have interest in contributing a chapter to the book to let me know. So if it's okay, I would just put a short video and then go with a further presentation. Is this okay? Okay.
Please proceed.
Can everybody see this?
Yeah, but can you put on the presentation mode?
Is the video to be seen or no?
No.
Wait, I will try again.
Yep.
Now?
Yes.
Okay, so this is the setting from our surgery. This is a patient who had the instability at the lumbar sacral area, and this patient had stabilization L5-S1. One thing I need to say, we use robots for all kinds of cases, not only for challenging cases like small pedicles or atrasias or deformities, because we believe that if you want to master technology, you need to know how to use it in a very simple case. So there are some straightforward cases where we use it in order to be able to use it then in a challenging case. So this is the screw planning. So these are the assets of the robotic arm: kinematic unit, tracking array, drill guide attachment, and this is the reference area attached to the spinous process. Robotic arm, CT, and navigation camera. We also put these skin fiducials for registration accuracy check. And the robotic arm is usually on the left side. We do there a separate small skin incision. We do intraoperative CT for automatic registration. Registration accuracy check is performed on the skin fiducials, and we fuse the preoperative and intraoperative imaging. So there is elastic and rigid fusion. We calibrate the instrument drill guides holder. So now I go with the robotic arm over the trajectory of the screw, and the robotic arm aligns automatically to the screw trajectory which we have already planned. And when it has aligned, this is what I see as a surgeon. Then this part is automatic. Robotic arm swings and comes into a steady position, which is then in the line with the pre-planned screw trajectory. And then I go with instruments, with draw car and with drill guide holder through the skin, make very small incisions, and in that way I go until the entry point on the bone. So this is the first step. We have now stopped using these small incisions on the side, but we use one big incision in the middle. Then we do the preparation until the fascia, and then we go through the fascia with this, because we've made an experience that if you do many small incisions next to each other, that's not very good for the wound healing. So this is now a drill guide. It's being locked, and then you track every instrument which you use. So you have, in every moment of the surgery, you actually know where are you with your instruments. One important remark, we use Circ robot from BrainLab. BrainLab is not a screw company. They produce softwares and medical instrumentation, but not screws. And that's why we can only implant the K-wire with that. One good thing about this robot compared to other producers is that it is a lot cheaper. And I personally don't have, also for disclosures, and I don't have any kind of financial or any other connection with this company, but my boss is a scientific consultant for them. So the development of these instruments is partly done in our department. So we do the drilling along the pedicle, we put the K-wire, remove the robotic arm, and then over the K-wire, we put the navigated screw. So this is the X-ray. This is the placement of the navigated screws with the towers. And especially 5S1 level is critical and problematic, because in this level, you usually have the situation that the screw heads are very near to each other, and that these towers also come very near to each other. We have the intraoperative CT, which shows the correct position. And this is the postoperative sagittal X-ray, which shows screw and cage position. Okay, thank you. That would be my first talk.
Thank you very much. We have one question in the chat box.
Yes.
So what is the incidence of a vertebral artery injury with the cervical spine pedicle screws?
In our department, it has not happened. There are series which describe it somewhere from 2 to 8%. It is it depends on who did the series. It depends on the literature review. It depends on the department, but it is very high compared to the vascular injury in thoracic and lumbar pedicle screws. And I think that will be the biggest asset of the robotics, when it enables us to place very safely pedicle screws in the cervical spine, because that is the most challenging thing when it comes to the robotic guided pedicle screw placement. You have now robotic guided laminectomies in an experimental setting. There are robotic guided places of cages. So the whole field of robotics is expanding, and actually the development of AI-driven modules, machine learning, deep learning, and all of the AI-related stuff in the last 4 or 5 years has now really rapidly developed the field of the robotic surgery, not only spine, but also cranial. And that is definitely the future, but we are now at the stage 0 of the development of these gadgets, because they need to be there needs to be a better ergonomics. It has to have a better haptic feedback. They have to be smaller. They have to be nicer to handle. But I think we are getting there. But it will take some time.
Thank you very much. So you can proceed with your second presentation on the microscope-based augmented reality in transpinodal surgery, Dr. Mirza.
Yes. Second. Okay. So My second topic, microscope-based augmented reality in transsphenoidal pituitary surgery and in skull-based surgery. So what is augmented reality? It is a significant advance. It provides a real-time updated three-dimensional virtual model of anatomical details, which is overlaid on the real surgical field. There is a special need for it to enhance the surgeon's perception of the surgical environment. The surgical field is often small, and surgeon needs to develop an X-ray view through the anatomical borders of the surgical approach itself in order to avoid unnecessary manipulation or inadvertent injuries to vascular nervous structure. And microscope-based AR allows overlaying 3D projections, which are derived from preoperative surgical images into bilateral eyepieces of the binocular optics of the microscopes, which is aligned then with the surgical field. So the concept is we have an MRI or CT. We fuse them. We take structures of interest, such as optic nerve, hypophysis, tumor, carotid artery, any kind of structure which interests us. We do the segmentation of the structure so that you have it in 2D and in 3D. And this plan is then sent to the operative microscope. And when you look through the microscope on the surgical field, you have an overlay of these structures to the real structures. And that's actually the point of microscope-based augmented reality. At our department, we have published extensively on this subject in spine surgery and also in cranial surgery. For example, in skull-based meningiomas and the transsphenoidal pituitary adenoma surgery, as well as acoustic neurinomas. We have started, our first paper was in 2019. We had then a consecutive single surgery series of 288 transsphenoidal procedure with smooth integration of AR into the surgical workflow with a very low target registration error, and with applying low dose protocols which reduce the effective dose. And this is one setting from the OR and one case. So this is the registration array and the calibration of the microscope. And here is a case of a pituitary adenoma. And in this case, we did the segmentation of the adenoma, of the optic chiasm, of the carotid artery, and of the optic chiasm with the optic nerve. So you have a possibility to do the segmentation in two-dimensional and three-dimensional way. This is the position of the patient during the surgery. So the position is, the patient is placed prone with a slight reclination of the head. We go through the right nostril. And this is the projection of the AR structures when you look it through the operative microscope, and when you attach the focus of the microscope. So when you go with the focus through the structures, you can have the overlay of all of these structures of interest during the surgery. So this is the microscopic view. In this case, you look through the microscope at the floor of the sella, following the drilling out the bone floor of the sella, and you see the outline of the tumor, you see the outline of the carotid arteries in the sinus, and you see the position of the optic chiasm. In that way, during the surgery, you know at every point of surgery where you are, where are your instruments, and you can then actually plan surgery, and it increases the safety. Of course, for an experienced surgeon, this is all maybe not necessary, but for the surgeons who are learning a certain surgical technique, in my particular case, augmented reality helps a lot because it gives you an additional security in the operative field. This is also a further case. And we have also a new paper then produced in 2022. This was a consecutive single surgeon series of further 165 procedures with and without AR support. There were no major vascular neurological complications, but the surgeon's comfort increased very much with the use of this technique, and that's why we would also recommend it. There was no difference in surgical time to set up patient, registration, prolonged intraoperative preparation by an average of 12 minutes. That is always the problem generally with technology, with augmented reality, with intraoperative imaging, with robotics, that it does prolong a bit an operative time, but on the cost of the increased safety of surgery. This is also one case at the very beginning of the surgery before removal of the septum. And you see actually these structures and these outlines throughout the surgery. But if you don't like them and you don't want to see them, you can always shut them off. And you can still, by adjusting the focus of your microscope, see how deep you are and at which structure you are at every moment during the surgery on a head-up display, which is right to the microscope. These are some further cases which show these reconstructions. And there are also other settings. Not in our department is, of course, not the only one which can do it. There is a lot of endoscopic pituitary surgery, and there are some tryouts to do the hybrid registration of the head before surgery, which captures anatomical landmarks, and the registration of the endoscope, which includes two steps: registration matrix, in which the length of the endoscope is defined, and the visual field. And endoscopes and neuronavigation screens could be appreciated in parallel, which is, of course, for colleagues who do the endoscopic surgery, very useful if they can use navigation and augmented reality parallel. And these are some excerpts from this particular paper, which actually show the outlines of the augmented reality in the endoscopic setting. One further advancement is also electromagnetic neuronavigation. This is a paper which I produced with my mentor, Professor 𝐸𝑛𝑡𝑜𝑟, whom I visited in the States for a fellowship in Memphis. He uses ACM, Medtronic electromagnetic navigation. And one big pro of this navigation is that you don't have to put the patient in the Mayfield clamp, and you can move the head of the patient any way you want, but this electromagnetic navigation enables an update of all structures the whole time, whereas the microscope-based augmented reality and the traditional navigation relies on immobilization of the patient's head or the spine. And in landmark identification, intraoperative navigation, accuracy, time, surgeon experience, in all of these things, the AR navigation has shown a positive effect. This is one of the recent cases. This is a patient with a microadenoma who had a morbus Cushing, and this microadenoma was very near the carotid sinus of the right side, so a very near relation to the carotid artery. And this is the beginning of the surgery. So the surgeon is behind the patient is in prone, the head is slightly reclinated, and these are the outlines which you see at the very beginning of the surgery. And when you adjust the focus of your microscope, then you see on the head-up display how deep you are and how deep are the structures which we are searching for. Outlines of the blue are the carotid arteries. Outlined in the yellow, this circle in the middle is actually the tumor, and the blue outline in the middle is the hypophysis, and the yellow outlines are optic chiasm and optic nerves. You can also put it in three-dimensional setting. This is when we have performed the drilling of the floor of the cella. And this is now the three-dimensional setting where you really see that the tumor is on the right side, as the imaging says, and its relations to the carotid artery. And this is during the surgery. You see here the typical yellow adenoma tissue, which is there where you expect it. And we can only recommend to try out this technology because it really increases the intraoperative orientation. And once more, invitation for everyone who are interested in modern technology to contribute to our textbook, which is going to be placed on spring 2026. Thank you very much.
Thank you, Dr. Mirza, for your wonderful presentation. So I think in the interest of time, we will keep the question and answer to the last session because we have 8 speakers. So I think it is now, it's my great honor and pleasure to invite Dr. Klaus Resch. Resch, are you online?
Can you hear me?
Yes. Can.
Okay.
So Dr. Resch is one of the founding members of ISMINS Society. So it is a great pleasure to have you today. So Dr. Resh will talk about the keyhole concept in minimally invasive neurosurgery in terms of intracerebral hematoma. So Dr. Resh, please present.
I have to test the one.
Yep.
Can you see?
Okay, yes.
But I cannot see. Yes, I can see here. So you see the first slide. Okay. Dear colleagues and friends, dear Professor Kato, I'm very proud to be here with you, and I thank you very much for this kind invitation. Of course, about this thematic on MIN, key concepts in MIN, I have to make some major comments before I start with the target of minimally invasive evacuation. This target of this pathology, ICH, has been left by the great masters. It has not been worked out by the great masters, so I had the opportunity to go into this field and to go on with minimally invasive techniques in this field. You know, the Stitch study made nearly a stop of ICH operations, at least in Europe. I don't want to comment this study now, but this is its own field. I don't want to go into this field now. However, we have to recognize finally, MIN is a divine concept. It is a divine concept. The reason is that neurosurgeons are a very, very small community of people in the history of mankind who have the opportunity and the privilege, the great privilege, to see the brain face to face. Nobody of the neuro family and nobody at all in history is belonging to this small VIP community, knowing the brain by face to face. This gives us a special obligation, We neurosurgeons have to care to protect the brain, not only in the OR, but also in society and also in technical development, to protect the brain and to protect the meaning of the brain. Excuse me. Does it work? Because I cannot see it. Is the next slide coming?
Yes, it's coming.
So we have to take care during the flow of the different phases of technical environment and technical development, that the technical flow and the flow of evolution is also an innovation flow. We always have to ask, is the flow that we are going on, is this flow really an innovation? This is a very important technique in MIN. Well, the roots of MIN were the Yashagil setting and the Panetsky setting. And we have learned if such a setting is changing, we are changing a world. We are going into a new world because we are going into new ergonomics. I will come to the point of ergonomics later. All these parameters change very much if you change from the Yashagil setting to the Panetsky setting. And we are going on in changing. And we have to keep in mind these two parameters. So what is innovation in MIN? You see in this nice, funny example, they made innovation, but is it really innovation in the meaning of MIN? The children tell us that it is not, of course. But now here, look, this is the birth of MIN, what you see on this slide. You see the question of Yashagil. Which area was really used in this glioma surgery? This is the area that was really used, and this is the approach. And this is the question, in which area was really used? This is a question about surgical reality innovation. And the question of Pernetsky, the next question of min birth was, can the really necessary area be planned? Can I plan this really necessary area before it comes to surgery? This was always the question of Pernetsky. So Pernetsky's question was also from standard or min. He changed the standard approaches to individual approaches. But if you see these images from a webinar of the United States, you see a lot of ergonomic mistakes. One of the most important ergonomic criterion is the ergonomic of OR setting. This is the Yashakil OR setting. This is the best ergonomic setting I ever found in the OR. In most countries, I found this ergonomic setting. The nurse is nearly beside and nearly behind the surgeon. This is maximal non-ergonomic. And in the Yashakil setting, the nurse is in front of the surgeon. He has not to move a lot to get the instruments. Also, the exposure area management, a great field of interest. I go not into details, but we have to consider how to deal with the hair and how to deal with the incision. This is a question also of microbiology. If you look to this, you see the correlation between craniotomy and corticotomy. It's also from a teaching clip from the internet. And the question is the exposure trauma, the surface of exposure and the volume of exposure. These are all criterions which will be important for minimal invasiveness. And you see that the surgery itself is not very difficult, but the correlation is very bad. And if you look to the possibilities we have today in MIN, you see the correlation between approach and corticotomy is quite elegant. And this is the approach, this is the result. Of course, this patient had a hemianopsia, and it was repaired very shortly after the surgery. He had the full recovery of the hemianopsia and all other symptoms, complete recovery. All these procedures, 99% of all my evacuation procedures are within 1 hour. And this is a very important moment, the 1 hour rule. I cannot go into details. You will find this all the cases you will find in the 4th volume. The case volume will come in the next month, I hope. And so here another example. Functional difference is in quality, not in quantity. So it is not a question of the size of the approach that makes minimal invasiveness. It is a question of functional difference, if you can preserve function or not. Quantity can be calculated. Quality must be described and imaged. This is a problem for surgery in general, that in our actual theory of science, we miss the criterion of quality. It has been pushed out about 100 years ago. The criterions of quality do not exist anymore in science. This is a major problem that we have to face in future. And the results of minimal invasiveness can be seen in the patient, must be seen in the patient. Otherwise, you have a problem. And the patient too, of course. And extreme conditions, extreme minimal invasiveness. I think it comes not from the technique, it comes from the conditions. Look, this is a minimal invasive procedure in preterm babies. And there you have extreme conditions because the volume compared to the adult brain is 300 to 500 milliliters. It is a premature tissue, and the body might be 700 grams. So you have really extreme conditions. In such cases, I mostly use only ultrasound navigation and a laser fiber. Only a laser fiber. Look to this small, tiny head and brain. We have to really have extreme techniques in such cases. Here, one case of Mexico, where I am regularly, and I'm a member of the international professor community there. Mexico has many children and many children with cystic lesions. So you have to use really extreme techniques. This is the way you are dealing there. Sometimes you even have not a possibility to use micro endoscopes, but only ultrasound and the laser fiber to cut the membranes, to make them connected, and later on to put a easy shunt into a very complex system. Also, another case, this boy was nearly dying in the MR, deteriorating in the MR, and we did not have time to finish the diagnostics. So we ran into the OR, and at this time I used the transendoscopic ultrasound. I call it brain radar because it makes an image like a radar. Here you see the anatomy of the fourth ventricle, and this is the anatomy of the transendoscopic ultrasound from the fourth ventricle. It looks like a mini CT at the tip of the endoscope. And you see here, this is a well-known situation, mammillary bodies, dorsum of sella, and perforation of ETV. And this is how it looks in the ultrasound. Dorsum of sella, basilar artery, posterior arteries, and here the tip of the endoscope and the transendoscopic ultrasound. So with this technique, I could navigate myself through this complex system to find the small point to make the ETV and to save the boy. And you see the brainstem is compressed completely to the clivus, and this is the fourth ventricle blown up very much because it's a closed aqueduct, stenosis, complete stenosis of the aqueduct. This is now the brainstem after surgery, and this is the flow that I could get. In these cases, we need extreme techniques, and one of these techniques, nearly forgotten, I published this in a book in 2005, transendoscopic ultrasound. I hope it will come back. Another case of a baby, just to show that in these children, by nature, you have an extreme situation even for minimal invasive techniques, and it was possible to show the tumor at this area and to make a biopsy and to make imaging of the tumor and then to start oncological tumor therapy because it was a medulloblastoma, a malignant medulloblastoma. And just to show you this video from the MIN video, and you see here a virtual creature that is diving into fourth ventricle with the brainstem and the choroid plexus of the here area postrema, area vestibularis, and stria medullaris, or the hearing fibers, and the dorsal part, foramen magnum and Marjandi. Here, foramen Luschke and plexus. So this is the anatomy there in endoscopic technique. So I go on, and you see bedside sonography is also.
Yeah.
Do you hear me?
Okay, now we can hear you.
Sonography is also okay. Sonography is also a forgotten, extremely minimal invasive technique. You can do it is a perioperative concept. You can use it everywhere, also intraoperative. And it is very well used bedside, because the patient don't have to come to the technique comes to the patient. This is minimal invasiveness. Diagnostics, planning, navigation, follow-up, and teaching. This can all be done by ultrasound. Don't forget the ultrasound. Without ultrasound, endoscopy will not proceed. And this is our goal in extreme min innovation. This is our goal, to keep the ergonomic sensitive center in the OR free of disturbances. This is the primary situation, the so-called chaos of the OR. And we have to change this chaos and to keep at least the most sensitive areas in the OR free of disturbance. This is our goal. And I will show now through slides on the theory of ergonomics, because ergonomics is also one of the key concepts in MIN. If you don't know about ergonomic, you will not proceed into the future. The first paradigm of ergonomics is that the OR is full of emergent orbits, and all these orbits have a different sensitivity ergonomically. Yes, and the higher the ergonomic sensitivity is, here in the center, the hand of the surgeon and the head, the more it will be affected if you make a disturbance. The next paradigm 2 is the procedural paradigm. The spatial paradigm was derived from the Gestalt theory. Very interesting theory, not well known in medicine. The procedural ergonomics is about the procedure, and it is derived from the chaos theory. And the operation procedure is a chaotic system. I know this is not nice to hear for surgeons. They believe they have all in power and in their hands, but indeed it is a chaotic system. Why? A chaotic system shows exact defined parameters, like in an operation, but its outcome is never really predictable. A chaotic system can only be influenced by its peripheral parameters. So that means be prepared. This is the worth, this is the benefit of this theory, paradigm 2, that you should look more to be prepared in equipment and design, physical fitness of the surgeon, mental fitness of the surgeon, light, gravitation, noise management, and so on in the OR, management in the OR, workflow, and training. Be prepared. This is the benefit of the ergonomic paradigm 2. Paradigm 3, the last one, is the most difficult one. It is mental ergonomics. Yeah, it is derived from neuropsychology of the surgeon. Each procedure on a patient's brain before happens in the surgeon's brain. Surgical effect results from action in the surgeon's brain. The surgeon's brain is the blind spot in our system, by the way. Haptic abilities result from recognition by surgeon's brain. So the brain of the surgeon is the main surgical instrument, and that means training in MIN means mental training. This theory of ergonomics is the red line into future for minimal invasiveness. And what you get is finally, and you could also imagine this in microsurgery and in future also, it is to train a mental navigation. You might see a very small area, but you know about the complete area. This is mental navigation. And if the new systems, the so-called exoscopes, if they will really make an innovation for MIN, we still don't know. We will see, and we have to follow it. So the optimal ergonomic solution would look like this. We have a non-contact support. We have a voice control We have the optic control by the head-mounted display, 3D, and we have a very tiny, small system in the OR so that things become modular, cheap, small, and changeable. This should be the future. Now coming to ICE evacuation that has been left by our great masters. So it was time, especially after the Stitch study, when all surgery of evacuation of ICH came nearly to an end. In the Stitch study, we have favorable outcome of 26.1%. And this was the reason why the Stitch study told us 20 years ago, we should stop ICH surgery. This was a great mistake. In my hand and my experience, by MIN techniques, we get 86% favorable outcome. And important is, MIN ICH evacuation is an interdisciplinary team concept. You need a very good team, especially by the anesthetists. And indication is made by neurological status, biological status of the patient, of course, and social embedding. Often forgotten, very important. Social embedding is very important in ICH patient. By the way, it is a benign lesion. It is a benign lesion. Why should we not operate this? And I come to this. And in the volume 4, I will present all the cases. Now, look, what we have in this concept that we avoid surgery of the hematoma, we will get a surgical trauma if we need to make a decompression, of course, and later you will see we also will have a biochemical tsunami. And if you want to prevent the pathophysiology tsunami by the hematoma to the healthy tissue, if you want to present this, you have to evacuate. And during the time we did not evacuate, during the last 20 years, most centers in Europe, at least, if not around the world, in this time, neurologists made a lot of great studies and great surgical and great science. But what they found is hematomas need to be evacuated. And you see here why. Because all these biochemical cascades occur 6 hours after the onset. This is the time when the destruction of the healthy brain starts. So we should go into, by MIN, very early into the hematomas to avoid the biochemical tsunami. And we should not consider many more science on defining parameters that can be dealt and therapied by medicaments, because this is nonsense. We can avoid most amount of physical and biochemical trauma to the brain just by minimal invasive evacuation of the hematomas. So you see here some cases. You know all what is happening with the brain if you don't evacuate. This is what you get. The lesion will become bigger and bigger, and once it is.
陈老师听得到吗？
吴教授你好，吴教授。
哎，你好，你好，看到哪个屏幕？
可以看到，
看到是吗？听到是。
Can you hear me?
Yeah, can. Well,
Okay.
we have 5 minutes to summarize. Thank you.
Okay, so and these are cases. This is what happens if you don't evacuate after a clipping, big hematoma not evacuated, aphasia for the rest of its life, and so on. And some examples, subcortical bleeding, and this is the result. Very easy to evacuate by a very small approach. And next example, this is a case of a deep-seated bleeding, and the patient sent me 2 months after stroke. She sent me a video that she was again skiing. Of course, approach management is very important, and preparation and planning is very important. Here, a hematoma, the boy deteriorated very heavily during the MR. So I evacuated the hematoma to taking care that I don't meet the angioma. Here's the angioma, here's the hematoma. So I made a very small bullhole approach and looked to the color of the brain. What is changing in the color of the brain, and we will meet very soon the hematoma. Was not difficult to evacuate. The question is how to evacuate. And now look to the color after evacuation. This is the normal color of the brain. So this is a very nice. And this is a case. This young 18-year girl was sent into the OR with 17 years. And she was operated 2 times with classical concepts and methods, finally by craniectomy. But then she was sent into the OR as a fatal case, and they started to examine if she has a brain death. So in the next morning, I made an ultrasound, and I saw she still have a very good vascularization, and perfusion was well at the limit, but it was still present. So I evacuated through a very small part of the approach, of the primary approach, and then she recovered and made ended her education very well. Last case, it was a bullet shot through the mouth, and also in this case, everybody was sure that this man will die. However, I operated him through this hole that was made by the bullet. Only through this hole, the hematoma and also debridement of the tissue. So finally, he recovered very well, and again he is still a driver, a car driver. And so finally, I conclude, MIN is a divine concept, and in the next volume, it will be about the pathophysiology. And I hope I can finish the next volume in the next half year. And I thank you for your nice listening.
Thank you very much, Professor Klaus Resch. Your fundamental concept on minimally invasive neurosurgery is very thought-provoking, and I always enjoy listening to your presentation. And we look forward to your next chapter of books. So because of the interest of time, we will proceed to the 5th presentation, and the question and answer we will keep at the end of the session. Okay. So it is my privilege. Thank you, Prof. It is my privilege to invite the next presenter, Professor Tadashi Watanabe. Okay, he will talk about minimally invasive endoscopic neurosurgery, keyhole approach, cylinder approach. Professor Watanabe.
Hi. Hi, good evening, everybody.
Good evening.
Okay. Can you see my presentation?
Yes.
Okay, so, thank you for giving me an opportunity today. And today my topic is minimum invasive endoscopic neurosurgery. And today I'm going to mention about the keyhole approach and the cylinder approach. Okay. And in my opinion, endoscopic surgery is roughly divided into 3 groups. One is the endonasal approach for paracellular tumors, and the second is a cylinder approach for ICH or intraparenchymal or interventricular tumors using a transparent sheath. And the third one is a keyhole approach for extraaxial tumor like a meningioma and schwannoma. And today we talk about these 2 topics, cylinder approach and keyhole. And first of all, I talk about the cylinder approach. This approach is originally from ICH surgery, which was developed by Dr. Nishihara from Tokyo. And I was really impressed about this paper, and I followed him and started endoscopic cylinder approach using a transparent sheath from a bar hole. And after some experience, I realized this procedure can be adapted to tumor surgery. And I began biopsy at first for like a malignant lymphoma. It was successfully done. And then gradually I began to start a tumor. This is my first case at the 2007. After stereotactic irradiation therapy for metastasis, the tumor was swelling and enlarged, and we did a necrotomy for this case. And necrotomy was quite easy for me compared to hematoma surgery. And we did a biopsy for the capsule. It was successfully done. And like this case was done maybe 2009. And at that time, there nobody did this kind of cylinder surgery, and repeated surgery have done for him by a craniotomy, and there was an infection or something. So he didn't want to do any more surgery, but this colloid cyst recurred. And we did a cylinder surgery through foramen Monroe. And we did a penetration of the cyst wall. The cyst wall was very firm, and we did a penetration at the 2 point at the bottom and the foramen Monroe. And then we started surgery for simple tumors like these, the small and well demarcated, and not so much blood supply tumors. And then we tried this kind of hemangioblastoma, as you know, which has bleeding nature. So we have to do coagulation of a feeder and precise dissection we need, because this nodule is attached to a brainstem. So we have to do a two-hand surgery. In this case, we tried a two-hand surgery underwater. While there is no bleeding, it is a really clear surgical field. But once bleeding happened, we have to make it dry. And again, we make it wet field. And now we almost the tumor is dissected. Now I'm observing the backside of the tumor. And the tumor is removed in this case. There's no complication for this patient. And intraparenchymal tumor is glioma. Glioma is one of the candidates for this surgery. But I think in my experience, glioma is a little bit difficult to do a cylinder surgery because it has no clear border. So that is why sometimes it is incomplete removal happens. But for glioblastoma, you can see the difference between brain and the tumor. After using a transparent test-up needle, we place a transparent sheath, and once you find the tumor, all we have to do is coagulation and sucking. This suction tip is connected with a monopolar coagulator, so we can do a suction and a coagulation. And so finally, we could achieve the subtotal resection, and we could make the tumor cavity like this. And we confirm hematostasis underwater and finish the surgery. And this is post-operative MRI. And let's move to the next topic, the keyhole approach. And this is for extra-axial tumor, skull-based tumors, like eyebrow or retrosigmoid approach. This is my first case for keyhole endoscopic approach. As you see, this is a simple tumor at the tuberculum cell, the planum sphenoidale. And I tried this method. And through this case, I felt the feasibility of endoscopic surgery. As you see, the visual field is much wider compared to the microscope. And we can see beyond the bony structure, in this case, beyond the tuberculum cell, we can see. And we could achieve the total removal. And we began to use endoscope for MVD, microvascular decompression. And gradually, I began keyhole surgery for complicated cases like this. This patient underwent surgery many times, and sometimes it was done by a very famous Japanese neurosurgeon. But as you see, this kind of in the midbrain, it is the tumor is compressing the midbrain like this. So especially this part, it is really difficult to remove. But using a 30-degree scope and using this kind of malleable tools, we could achieve the maximum resection of this thick membrane. And also we could look down around the medulla. So we could achieve total resection of this tumor. This pre-op and post-operative MRI. And this is a clinoidal meningioma. From eyebrow skin incision, we approached. And as you see, if there is a 2 by 3 centimeter keyhole, the microsurgery is possible. And this is a right optic nerve, and now the surgeon is dissecting the tumor. So, okay, this is post-operative MRI. And through my experience, we found like this. We noticed the keyhole 2.5 or 3 centimeter size is the best, because the retraction of the brain is limited by the craniotomy itself. And the endoscope or surgical instruments are stabilized against the craniotomy limb. So it should be a little bit smaller. If the craniotomy is really big, endoscope is unstable. And if it is less than 2 centimeters, the space is very narrow. So 2.5 or 3 is good enough for space. In case of emergency, it protects the brain from the surgeon. We have to do through the keyhole if the emergency happens. And we can do like this case is multiple Faucin meningioma, the patient with NF2. After removing the big one at the center, we can remove the daughter lesion along the falx. So along the falx there is a space. There is a free space. There is no bridging structure between sagittal sinus and corpus callosum. So once you enter the endoscope, there is a really wide surgical field, and you can do a manipulation beneath the bridging vein. And also, this is another typical endoscopic surgery. We can remove the tumor on the ceiling. So we approach this tumor, the tentorial meningioma, at the confluence of the sinus. It's a so-called auricular meningioma. We approach from below, and we can do a resection from below, and the tumor on the ceiling. And this is another concept, the extremely minimum invasive surgery. This patient is 85 years old. And this patient began to have a symptom like a floating sensation, clumsy hand. So, but 85 years. So we planned maximum decompression, maximum internal decompression without exposing the brain or CSF. So when we use the endoscope, we can do maximum internal decompression. So in this case, we didn't expose any brain, or we didn't drain any CSF. So on the very next day, he is like this. The symptom improved, and there's no headache, no nausea, no vertigo, no ataxia. She is using a chopstick very nicely with right hand. This is postoperative 1 CT, and 1 week after the surgery like this. And the 2 months after the surgery, the capsule is shrink like this. And this kind of complex pituitary adenoma, we proposed a combined surgery with the supraorbital and the endonasal approach. So when using a 2 minimum invasive corridor, we can, fight with this kind of complicated cases. So we use the exoscope first and change to the endoscope from the eyebrow. And on the other hand, and the nasal team started simultaneously the surgery. So in this kind of case, the running of the third nerve is really the important issue, and the nasal team find the third nerve inside the tumor, and we can share the information with the other team. And then mostly the tumor was removed in this case. And transient third nerve palsy was happened, but 4 months after the surgery, it recovered. And recently, we started using an exoscope. We started 3D exoscope from 2018, and we started Olympus OVI from 2021. Visual access is quite free with this instrument. And we started, the teamwork surgery. The scopist precisely controlled an endoscope. 2 surgeons will do this surgery with the endoscope. And we published a paper which shows a significant difference between classic, microscopic surgery and endoscopic surgery. There was a significant difference in blood loss, operating time, length of a hospital stay, and the size of a craniotomy. Okay, so, and this is the case. This is some unique case. There are the two meningioma. One is on the frontal base, and the other one is a middle fossa. And from this keyhole around the pterion, we made a 2.5 centimeter craniotomy. And first we used the exoscope. Exoscope could observe the tumor attachment. But in this case, we have to change to endoscope to observe the temporal base tumors. And here you can see. Once you use an endoscope, we can see everything through a small keyhole. And in this case, actually, she denied the incision at the face, at the eyebrow. So we chose the hairline cut incision. Actually, this picture is taken 2 weeks after the surgery. So skin incision like this, but we made a keyhole like this, preserving the temporal muscle. Actually, we need only this space. And we find this is a really unique case, the angioma inside a chiasm. We have to remove the angioma from the optic nerve. So it is a really nervous surgery. But in this case, we did a wet field underwater surgery with an endoscope. And we did a removal as much as possible. And we could remove the, the subtotal removal. And then her symptom improved. Okay. And this is the last case. We also use wet field underwater surgery for MVD. So first we do a rough arachnoid dissection, and once we find nerves, we change to the endoscope, and underwater surgery we do. And it may be good for the nerve, and especially for eighth nerve. So most of the time we use a wet field surgery. And after placing the felt, we do a fixation by a glue, and then finish the surgery. Okay. And this is my conclusion: endoscopic cylinder surgery for intraparenchymal, intraventricular lesion, and the endoscopic keyhole surgery for extraaxial scalp-based lesions are less invasive and safe. Thank you.
Thank you very much, Professor Watanabe, for a very nice presentation, excellent technique, and very clear video. So we'll keep the question and answer at the end of the session. So now I shall call upon the sixth speaker, Professor Takehiro Uda, who will talk about the endoscopic corpus callosotomy for minimally invasive surgery. Professor Uda?
Yes. Can you hear me?
Yes.
Yeah.
Okay, can you proceed with your presentation? Thank you.
Yeah. So, hello everyone. My name is Takehiro Uda, and from Osaka Metropolitan University. It is my great pleasure to speak at this meeting. Today, I will be talking about endoscopic corpus callosotomy for minimally invasive surgery. As you know, corpus callosotomy is a procedure for epilepsy that aims to palliate seizures, particularly for drop attacks. It has been performed for over 70 years, and it is widely regarded as a standard treatment for epilepsy surgery. The key question is, how to make this standard surgery less invasive. With advancements in endoscopy, Professor Sood from Michigan University and Professor Chandra from India shared their reports in late 2010s about using endoscope for corpus calostomy. Here, I will explain our endoscopic corpus calostomy procedure. In this method, we use a smaller craniotomy compared to the conventional microscopic approach with a diameter of about 4 centimeters. We also make a straight scalp incision instead of the curved one, placed right above the craniotomy site. The endoscopic approach allows surgeons to see a wide view at the deep surgical area, even with a smaller opening. On the other hand, in microscopic surgery, surgeons need to adjust the surgical angle from outside the skull. Let me introduce one case presentation. This is a typical case of a patient who underwent corpus calostomy. The patient was a 60-year-old male diagnosed with Lennox-Gastaut syndrome. He had a history of perinatal hypoxia and had been dealing with tonic seizures. His EEG showed a bilateral multifocal epileptic discharges during the interictal state. And his MRI revealed bilateral cerebral atrophy caused by perinatal hypoxia. This is a surgical video of anterior 2/3 corpus calostomy using an endoscope. The patient was placed in the supine position with no leg rotation. We introduced the endoscope and began interhemispheric dissection. The arachnoid was cut, and the interhemispheric fissure was dissected using a bipolar or scissors. And dissected the cingulate gyrus meticulously and reached the corpus callosum. Now you can see a 1 centimeter of corpus callosum between the bilateral pericallosal arteries. Yeah, after exposing approximately 1 centimeter of corpus callosum, we began the corpus callosal section using a QSAR or a bipolar forceps suction or something. At the deeper part, we identified the cavum of septum pellucidum, which serves as a landmark for the depth of the callosal section. By opening this space, surgeons can confirm the completeness of the callosal section without opening the lateral ventricle. We proceeded until reaching the rostrum of the corpus callosum. Here you can see the pericallosal arteries beyond the corpus callosum. This is at the most anterior part, the rostrum. Then the angle was adjusted posteriorly, and the callosal section was continued until reaching the isthmus of the corpus callosum. All procedures was done with under the endoscope. The dural opening is about 3 centimeter and a linear skin incision. Next, this is a surgical video of posterior 1/3 corpus callosetomy. The patient was placed in the prone position and linear skin incision and a small craniotomy and introduced endoscope. In posterior colostomy, the corpus callosum can be accessed directly without arachnoid dissection. After reaching the splenium of corpus callosum, we started the callosal section. And here you can see the vein of Galen through the arachnoid. After completing the splenium section, we adjusted the surgical angle anteriorly and continued the callosal section. At this point, the cavum of septum pellucidum can be observed here. Once the completeness of the corpus callosetomy was confirmed, we check the hemostasis. And then wound was closed anatomically. Yeah, small craniotomy with linear scalp incision. This slide presents the comparison of the endoscopic view, the left side, and right side is a microscopic view at the deepest part of the procedure. In endoscopic surgery, we can obtain a clear and wider view, even with a small craniotomy. This is from our case series. In our case series, a comparison between endoscopic corpus callosetomy and microscopic corpus callosetomy reveals that the size of craniotomy, left side, size of craniotomy was significantly smaller in endoscopic approach, while the operation time and complication rate were comparable between the two approaches. And we concluded that using an endoscope makes corpus callosetomy less invasive. Recently, laser intestinal thermal therapy, LIT, has been reported as an alternative option for corpus callosetomy. However, according to this report, the surgical time for laser therapy is longer because LIT requires multiple trajectories to complete the callosal section. In addition, the possibility of unwanted residual areas need to be cut was pointed out after laser therapy. I'd like to briefly summarize the key points of my presentation. Corpus callosetomy is a standard epilepsy surgery that needs to be minimally invasive. Compared to a conventional microscopic CC, endoscopic corpus callosetomy is less invasive due to the small craniotomy size and demonstrates non-inferiority in terms of complication rate and operation time. On the other hand, late CC requires a longer surgical time, and some cases resulted in incomplete callosal sectioning. At present, it cannot be considered a minimally invasive option. I thank all my mentors and colleagues who have contributed to our work. Thank you for your attention.
Thank you very much, Professor Uda, for a very nice presentation and very elegant technique of endoscopic colostomy. So we will keep the question and answer at the end of the session. So now it is my pleasure to invite the seventh speaker, Professor Hirofumi Nakatomi. So he will talk about monitoring based minimally invasive functional preserving neurosurgery for vestibular schwannoma and brainstem cavernoma.
Okay, my name is Ishiro Nakatomi from Kyoto University. Can you see my slides?
It's working well.
Okay, good. So
Thank you.
I'm talking, first of all, thank you very much. I cordially appreciate the invitation to Minimally Invasive Society. I cordially appreciate Yoko Kato and other faculty members all over Asia. Thank you very much. I'm going to talk about our monitoring-based minimally neuroinvasive functional preservation surgery, particularly for vestibular schwannoma and brainstem cavernous malformations. For most of us, the ultimate question when we dealing with vestibular schwannoma or brainstem cavernous malformation would be, how could we precisely visualize these nerve or nucleus or tracts before the operation? Or how could we preserve neural function associated with these? Then to overcome these two questions, we have invented this type of 3D computer graphics surgical simulation software from 2010. Now it's commercially available. The name is GRID. Then you can overlay everything, tract and nucleus or other nerve alignment too. Then also for the vestibular schwannoma, since now the main focus is going to the hearing preservation, we developed this type of the new cochlear nerve monitoring since 2006. Instead of record from the pinna, we record directly from brainstem dorsal cochlear nucleus. Then we created this type of plate electrode we call DNAP electrode. Then whenever you can put the electrode right on the dorsal cochlear nucleus, you can measure the auditory evoked responses 20 times bigger. Takes only 7 seconds, and it is very stable, even several surgical manipulations. We established this monitoring from 2006. Then also another advantage of this dorsal cochlear nucleus action potential is we can differentiate the cochlear nerve bundle by stimulation. Whenever we touch the real cochlear nerve fiber, the DNAP electrode can record 2 double peak responses. While if we touch only the tumor capsule or vestibular nerve bundle, it creates just 1 single peak response. Also, we revised the continuous facial nerve stimulating electrode so that we can put the electrode right on the facial nerve nucleus instead of the nerve. The facial nerve root is sitting right behind the glossopharyngeal nerve. So whenever you can dissect the glossopharyngeal nerve, you can put this electrode too. Then let me start from this case. This gentleman came with 3.4 centimeter acoustic neuroma with good hearing. Then we simulated preoperatively the green through the retrosigmoid right side approach. The cochlear nerve bundle is estimated green. Facial nerve bundle has been estimated as red. Then we thought these two important nerves are passing side by side caudally. So this situation gives us the best chance to preserve hearing and the facial nerve. Then this is the operation through the right retrosigmoid approach. We put the green electrode right into the foramen lusca to start the cochlear nerve recording. Then by stimulation, we figured out the cochlear nerve bundle has been aligned caudally. Then after confirming the position of cochlear nerve, we aim to take out far cochlear nerve side tumor entirely. Then after taking out the most of the tumor, we shape the remnant along the cochlear nerve so that we can take out nearly entire tumor without touching the nerve. Then this is a cochlear nerve mapping view. Whenever we touch the real white bundle cochlear nerve, we see the double peak response. If we touch right on the tumor, we just see the one peak. This advanced monitoring will give us the safer understanding of the how the exact neural anatomy works. Then this is the final, actually the intraoperative neural trend graph. On each operation, we start recording from the beginning to the end how much % of the neural function has been preserved real-time manner. For the first two columns is responsible for facial muscle, ocular muscle on the top, oris muscle on the second. The third column is ABR interval, and the fourth column has the DNAP amplitude. Then we figured out for functional preservation of hearing, we need to maintain over 40%. Let me show another case. This lady came with huge 4.5 acoustic tumor with good hearing. Then we simulated, but if the tumor goes more than 4 centimeters, sometimes we cannot see the nerve alignment correctly. We just estimated the vascular anatomy. Then we started the same operations. Through the left side retrosigmoid approach, we put the green electrode right onto the foramen lusca. Then this white bundle has been the cochlear nerve. Then beyond that, we confirmed the facial nerve. Then we dissected the subtentorial trochlear nerve. Then we created a safer margin of the cochlear nerve bundle along the real cochlear nerve. Then we started debulking with scissors. As long as we know precise neural nerve anatomy position, we have only to avoid the real monitoring response drop down during the operations. If we see a sudden abrupt response decline, you need to avoid the similar or same surgical manipulation on the same place. Then for this particular case, from the beginning to end, facial nerve response has been preserved, but we see some drop. Then whenever we see the response decline, you need to change the surgical action and speed and the place so that you can keep damaging the nerve. The same scenario is true for cochlear nerve. Even for the huge 4.3 centimeter acoustic neuroma, since she has a nice cochlear nerve position, we have only to avoid the fatal, irreversible, constant action to the cochlear nerve. Then, fortunately, this case got the hearing preservation, and we finally noticed over 290 cases of use of this monitoring. To keep the facial nerve normal, we need to maintain the response more than 60%. If you aim to House and Blackman 2, you have only to keep more than 50. Then our series achieved the 96.3% facial nerve preservation for 2.59 per centimeter tumor. Also for hearing, through the 96 patient DNAP monitoring use, we notice hearing preservation, we need to maintain the DNAP response more than 30%. Then ultimately, we have our hearing preservation rate is 68.8% through this surgical monitoring system for mean average 2.22 centimeter acoustic tumor. Then the same surgical monitoring action device strategy can be applicable for brainstem cavernous malformation too. It's a conceptual illustration, but the within the brainstem, those somotomotor, visceral motor, and visceral sensory, and the somatosensory nucleus column has been aligned from the medial to laterally. Then conceptually, we can cut between these two columns. As far as we know, this conceptual nucleus columnar alignment position, you should be able to incise brainstem more confidently. Then let me show one case. This lady came with mid-pons cavernous malformation with hemiparesis, hemesthesia, and 6 nerve palsy. Then we started the simulation. This is sort of the 14 years of surgical simulation training achievement. We used these monitor simulation for most major cases over 14 years. Then we use this simulation for surgical planning. We simulated transtentorial occipital approach and fourth ventricular approach. And first anterior petrosal subtemporal approach didn't give us the nice surgical view because this lady had the anterior aligned motor and sensory position here. So we decided to go through the fourth ventricle. Then through the midline suboccipital approach, we open up the ubrotonsillar and the lateral cerebromedullary fissure with microscope. With the advancement of today's colleagues, faculties, endoscopic surgical instrument, we might be able to same procedure with endoscopic technique soon. But advantage for this approach is we can put the continuous facial nucleus electrode right onto the facial nerve colliculus so that we can figure out facial nerve function has been preserved or not intraoperatively from the beginning to the end. We prefer to dissect these cavernous malformation capsule directly from the other gliotic tissue. But again, since our microsurgical result is now close to the maximum best result, after establishing this surgical setup, we might be now able to this technology to be applied to the endoscopic surgery too. For this lady, she has some SEP and MEP drop down during the anterior part of dissection. But whenever you stop, whenever you notice the sudden drop of the response, you can change the pace and speed of dissection so that we can stop the permanent damage. Then she has no worsening And we had 25 cases. Sorry. Particularly from the anterior approach, we have less and less complications. Then we noticed for MEP, we needed to maintain more than 40% for the same strength. Then for facial nerve, particularly even for the brainstem cavernous malformation, we needed to maintain more than 40%. Then this is conclusion, surgical simulation and the real-time continuous monitoring has been applied for the, our concept is neuroprotective minimally invasive surgery. Thank you very much for your attention.
Thank you very much, Professor Nakatomi, for your elegant technique. You have demonstrated very well the use of this virtual preoperative simulation and intraoperative monitoring to achieve maximum preservation in your practice. It was very good. So we will proceed to the last presentation from the eighth speaker, which will be by Dr. 𝐻𝑖𝑟O𝑘𝑖 𝑀ＯRISAKO on the topic of endoscopic transcranial keyhole surgery for extra-axial lesion. You may say your slide, Dr. 𝑀ORISAKO.
Okay, so I will prepare. So can you show
Yes.
this slide? Okay, so
thank you.
So thank you very much for the kind invitation for such a wonderful minimum invasive surgical web seminar. So my name is 𝐻𝑖𝑟Ｏ𝑘𝑖 𝑀ＯRISAKO from the Department of the Neurosurgery, Osaka Metropolitan University. And today's my topic is endoscopic transcranial keyhole surgery for extracranial region. So recently, the endoscopic surgery has been introduced in the management of the intracranial region with including the indication. So in our institute, the number of the cases of the endoscopic keyhole approaches for the extracranial region, there has been gradually increasing the number. Recently, the total number of the cases over 70 cases. So I will show some cases. So this is our basic setting for the endoscopic transcranial keyhole surgery. We usually adapted the four-hands endoscopic surgery by two neurosurgeons, the main surgeon and the scopist. They both collaborate and remove the region. So I will show this case. This is Fox meningioma locate the middle third location. This is a cadaveric dissection of the contralateral transversing keyhole approach. Compared with the microscope and the endoscope can be used in close proximity to obtain the wide-angle view and clear surgical field. So usually we use the endoscope for the Fox meningioma recently. So this is a surgical setting and surgical video. We make the relatively small 3 centimeter craniotomy, and after cutting the dura mater, we introduce the endoscope. After cutting the parts, this is a normal parts, and make the surgical corridor the caudal side and little the posterior side. We could identify the anterior edge of the tumor, and also cut the parts the posterior side along the posterior edge of the tumor. And after that, we started to the internal developing of the tumor. After the internal developing, we make the surgical corridor more posterior and caudal side along the tumor, the attachment, and after completely detachment of the tumor, the tumor, the color of the tumor to change the whitish and completely devascularize. So after this situation, the tumor removal not so difficult with the decrease the size of the tumor and peel off the tumor from the surrounding the arachnoid and rotated the tumor and split of the tumor. This is the calcium and the cut and dissected from the surrounding vascular structure and remove the tumor. This is the final piece. We achieved the Simpson grade 1 tumor removal. So this is a post-operative MR image. Tumor was completely removed without any complication. So the chromosome size, like this, very small. So we already published the data of the contralateral transferring approach. So the result is the comparison of the endoscope and the microscope. The surgical result, the clinical outcome is same, and only the operation time reduced in the endoscopic series. So next, this is I will show the endoscopic supraorbital eyebrow approach for the tuberculum cellular meningiomas. So by using the endoscope, we can drill out the tuberculum cellular and also open the optic canal and the tuberculum cellular, and we can remove the attachment of the tumor of the dura mater. So this procedure is very adapted for these little small to the medium size of the tuberculum cellular meningiomas. I will show this video. After the small frontal colonoscopy, we inserted the endoscope, so we could identify the margin of the tumor attachment. At first, we drill out the frontal base and also drill out, open the optic canal, and also drill out the tuberculum cellular. So at the time we already detach and devasculate tumor as much as possible. After that, we can open the optic canal and started to developing of the tumor. The size of the tumor not so large, so the adhesion of the tumor and the optic nerve so not so severe. So we could keep the not the hemorrhagic view. So we could remove the tumor, including the attachment. So the Simpson grade 1 tumor removal was achieved also in this case. So the reconstruction is very simple. We put the abdominal fat and close the wound and finish the operation. So after the operation, the patient visual symptom improved immediately after the operation. So we also published the data, the 2023. So the comparison of the microscopic approach and the endoscopic approach, the result is same of the falciparum meningioma. The surgical time reduced, and the outcome not so different. So next is I will show the subtemporal, the anterior transpetrous approach. So this is the trigeminal schwannoma. The tumor located the Meckel cave and the posterior and also the extracranial region. So in such a tumor, endoscopic subtemporal keyhole anterior transpetrous approach is very useful. So I will show the detail of the procedure. So this is a skin incision. about a 7 centimeter coronal incision is made from the anterior side of the auricle, edge of the hairline, and curve the posterior side regimented in the linear fashion, and make the 4 centimeter temporal craniotomy. And after that, inserted the endoscope, subdural the approach, and we can identify the GSPN, and the Kawase triangle is drilled out. And after that, the tentorium is cut, and after opening the mechanical, the cranial nerves fall, the fifth, and SGA and anterolateral surface of the bones are well visualized through this approach. So I will show the one video. So after the relatively small the temporal craniotomy, we insert the endoscope, the subtemporal root, and identify the location of the GSPN by using the facial monitoring. And after exposure of the triangular Kawase, we drill out the small part of the petrous ridge and open the Meckel cave, and we started to the internal developing of the tumor. This is the tumor occupied the Meckel's cave, and we added the drill and the posterior side, and we cut the tent and open the Meckel's cave more posterior side. So we could reach the tumor extend to the posterior fossa. So tumor was removed piece by piece. Like this, and of course the some ultrasonic accuser is very useful for such the keyhole surgery. And after that, the residual tumor was located extracranial side. So we drill out around the foramen ovale and enlarge the surgical corridor, and expose the tumor protruded to the foramen ovale, and remove the tumor. Finally, reach to the bottom of the tumor. So by using the endoscope, we could achieve the radical removal of the tumor in this case. This is the posterior posture. Yes. So this is the post-operative MR image. The tumor was radically removed. So we already published the initial data of this by using this procedure. So the comparison of the microscopic procedure, the operation time, and the blood loss, and the number of the post-operative new temporal lobe edema is decreased. So this is maybe the less invasive procedure. So how about this one? So this is the recurrent of the epilepsy. The patient already they had several times of the transcranial procedure for remove the tumor, but the regional tumor grown up, and the tumor region occupied the middle fossa and the posterior fossa, and also the protruded upper side through the lateral ventricle. So in this case, we also adapted the subtemporal, temporal craniotomy and the endoscopic procedure. After the small craniotomy, at first we make the surgical corridor, transcortical route for the inferior form of the ventricle, and remove the tumor of the around the midbrain, and the tumor was system was removed. And after that, we removed the tumor around the lateral ventricle and the upper side. And this is a subtemporal root. And we removed the tumor around the interpenetrator system. After that, we added the anterior transpetrosal approach, and drilling out the petrostone and make the surgical corridor of the caudal side trigeminal nerve, and remove the tumor around the 6th nerve and 7th and 8th nerve. So the tumor was tightly adhered mainly the nerves and the arteries. So we necessarily remove the tumor as much as possible through this procedure. So this is a post-operative MR image. The patient didn't show any additional neurological symptom. The patient condition is good. So this is one of the cases of the elderly patient of the acoustic neuroma. The patient already lost the hearing, but the patient showed the hearing gate disturbance. So in such a situation, the radical removal of the tumor was not required. So we selected the endoscopic procedure. So the patient position supine lateral and linear skin incision and relatively small suboptical craniotomy, and we inserted the endoscope and evacuate the CSF, and this is a petrosal fissure, and we cut the surface of the cystic component of the tumor and evacuate the content of the cyst, and after that we evacuate some the solid component of the tumor gradually. This is so the ventral side of the tumor. So we check the cystic component of the tumor clearly through the endoscopic view. So the solid component of the tumor was removed as safe much as possible, and we finally we reached the ventral side of the tumor and identified the 6th nerve and the partial artery. So we finished the operation. So after this procedure, the complex of the brain cell was released completely. The patient condition is good, recovered. And this is the final video. This is midbrain, the capilloma, and the region that has been gradually grown up 3 years. So we adapted the endoscopic, the optical transventricular approach for this case. I will show the video. We make the small craniotomy and insert the endoscope, the graduate evacuate the CSF, and after that we cut the tentorial. So by using the endoscope, we can put enough the surgical corridor, and after the dissecting the silicon arachnoid around the galenic system, we reach to the just behind of the region. So we reach to the cavernous angioma like this, and we dissected the region from the surrounding the brain, the parenchyma, and coagulate the abnormal B cells meticulously So the procedure itself is almost the same of the microscopic view. So after the complete dissection of the lesion, we remove the tumor the en bloc fashion like this. And this is the post removal of the lesion. So through the deepest side, we could see the third ventricle. So the venous structure completely preserved. So the patient, they didn't show any neurological symptom after operation. So the result is good. So this is this table showed our trend of the endoscopic transcranial keyhole surgery for the X-ray axial region. So I think there are some level of the difficulty. At first, we started the subfrontal or paroxysmal lesion, and gradually indicating of the indication was enlarged, and recently with adapted lesion for the posterior fossa or the cavernous sinus region. So in our institute, Professor Hekuba, Professor Ohate, Professor Goto, the contest modified the skull-based approaches for the safe and maximal tumor removal. So the basic concept of the tumor removal for the extract lesion, we think there are the two important concepts: how to access the center of the tumor and how to develop the tumor. According to the surgical selection of the approach, usually we select the approach does not beyond the important neurovascular structures, and also the preoperative planning also very important. So we usually always think the balance of the maximal tumor removal and minimal invasiveness while preserving the function, and also to achieve such purpose, the four-hands surgery enable the neticulous detection of the deep-seated tumor with such safe surgical corridor in case of the selective lesion. So in conclusion, endoscopic key flow approaches for intracranial lesion are considered to be one of the new surgical techniques that can be expected to develop in the future. Thank you for your attention.
Thank you very much, Dr. Hiroki Morisako. So for very nice presentation, you explained very well your operative techniques, strategies, and you use endoscope as primary visualization tools. And you managed to remove a varieties of lesion, extra lesion beautifully. Thank you very much. Now I would like to call upon all the speakers, if you can join me in the webinar. So I think we have a quite limited time for question and answer. So we have one question in the chat box by Rahim Bello. So his question is, I am happy to be here today listening to living legends in the field of minimally invasive. I am from Nigeria with a lot of technology gap in the area of MINS. I want to ask for mentorship on this area for a neurosurgeon in training from low-income country like mine. So this question probably I pose to maybe Professor Yoko Kato first, and maybe the rest speakers who probably can offer something for young people, especially from Nigeria or other low-income country. Professor Yoko Kato?
Thank you very much for very difficult questions. But I think I want to ask all the speakers, how do you think about what is the most important instrument or tool you think such a low-income countries? Maybe endoscope, or how do you think? Klaus?
Well, as you know, in my opinion, I always talking about the ultrasound, because ultrasound is a perioperative tool that can be used everywhere in the hospital, intra and outside of the OR, and it can it is doing a excellent imaging, and it does not only image the anatomy, it also image pathophysiology. So this is very unique in ultrasound, and ultrasound machines are much more cheaper than other imaging machines, and they are elegant, they are small, they are modular, and they can fit very nicely into the operative flow.
Thank you so much. Azmi?
Okay, I think for beginners, for minimally invasive, I think first they must start the anatomy, and number two, I believe endoscope help for certain cases, but not all. But you can still use your basic microscope, but you can implement the keyhole concept. Importantly, to preserve the anatomical function while you have your optimum outcome from your surgery. And most of the complications sometimes happen in the beginners, especially when they thought that with the small incision, everything can be removed. So without respecting the underlying anatomy. So this is what I learned during my early part of, learning in minimally invasive, especially when you look at the presentation by legend like what we have today. So then you start to imitate immediately. Then you realize that the learning curve is actually from basic is still anatomy, and number two, know your equipment well and the limitation of the endoscope as well. So I think that is my simple advice. Okay, we have one person, Muhammad MD Shanawaz Biswas, who raised hand. Probably you want to ask a question?
Hello, Sensei. Can you hear me?
Yeah, we can hear you.
Thank you for the opportunity. I would like to ask 3 questions, Sensei, if you allow, as a beginner, as a young neurosurgeon, to go with the endoscopic keyhole surgery. Number 1 question is, sometimes when we try to drill, the drill gets entangled through the corridor. So do you have special tips for that? Number 2 is, what are the contraindication I should not go with the keyhole endoscopic surgery, especially in tuberculum cell meningioma or trigeminal schwannoma subtemporally? And number 3 question is, when I go with the eyebrow incision, I don't like to put any drain, but I gets very swelled up. So do you have any special tips during the incision, up to craniotomy, so that I can reduce the swelling of the eye? Thank you.
Maybe Hiroki, you would like to answer that question? Hiroki Morisako, can you unmute?
Yeah. Okay, so so thank you for your nice question. So first question is, so we usually use the slight cupped special drawing for the so such a small such a small keyhole corridor. So usually so in our as you don't know, our tip of the door is very the shaft is not very short, so it's a very safe concept, safe the drill. So maybe that when we plan the keyhole surgery, maybe some so special the drilling is very important. And second, so when we select the surgical procedure, so the location of the lesion is most important. If the tumor, so in the case of the trigeminal schwannoma, so if the tumor located Mechanical scale, only the mechanical scale. The endoscopic endonasal approach is one of the options. But if the tumor protrude the posterior fossa, maybe the endoscopic procedure is not enough. Maybe the subtemporal or the with the drilling of the petrous bone is required. But on the other hand, if the trigeminal the extent for the SOF, the supraorbital fissure, in such the tumor, maybe the orbital approach is adequate. So we think which approach is the best for the lesion. So finally so what is the third question? So please again there.
Sensei, while going through the eyebrow incision,
it
often gets swelled up. I mean, the black eye and due to cosmesis.
Yes. So I haven't know the good solution of the. Sometimes the patient show the swelling, but maybe that is some patient occur. So so that maybe so cosmetically not the linear, some the S shape or the zigzag the skin incision is the cosmetic for the scar after the operation. So maybe some of the design is very important for the cosmetic problem.
Oh, thank you, Sensei. Thank you.
Is there any other input? Yes, Rash.
There is one factor that is often overseen, and this is the positioning of the patient. The rule of the positioning of the patient in minimally invasive neurosurgery is overseen, but the principle is once you have a minor factor, and this factor is lasting throughout the whole operation, the whole procedure, it becomes a major factor. So some minor factors in minimally invasive neurosurgery are overseen, but these factors should be named, and one of these is the positioning of the patient. Second, for the first 8 to 12 hours post-operatively, you have to drape the wound very strictly. Yes, for 8 to 12 hours in the beginning after surgery. Yes, this will help.
Okay, thank you. We have actually Professor Vladimir Benes who managed to join us shortly, but he has a surgery and he finished late and he just left us again. But thank you very much. So I think in the interest of time, maybe any one of the speakers who would like to mention anything as your last message for the audience.
I think maybe I want to ask Nakatomi Sensei about the 4 young doctors, how they need to learn the anatomical things, such as the surgical anatomy, not basic anatomy.
Oh, okay. Thank you very much for asking me. I think this is the future of our next generation neurosurgeon. Minimally invasively taking out the classical large meningiomas or large aneurysms or any other stuffs can be the target of this minimally invasive surgery. But as Professor Morisako's group has pointed out, if we are taking out the tumor, we have to be aware about where is the feeder, main feeding centers. Number 2, where is the surrounding eloquent structures. Number 3, which sequence we should develop from the northern half or southern half. this type of the main surgical principle would not change. Then, as you, Professor Kato told me, the general anatomical knowledge is most important, but it's been always required for everyone. But for whenever you attack the surgery, the case, you need to be familiar with the certain surgical anatomy for this unique patient. In that meaning, this surgical simulation will help to achieve more and more concrete surgical strategy, particularly for difficult case or whenever you do the minimally invasive manner. I think we need to use both virtual surgical simulation learning plus real cadaveric dissection course. Those two can be help each other to facilitate your understanding, particularly for the younger generation.
Thank you so much.
Thank you very much. So any final words, maybe from Prof. Resh?
Yes, I want to remind to this young resident that we should not forget, beside the anatomy, the pathophysiology, because MIN is not an anatomical concept. It is a pathophysiological concept. Therefore, I always remember also the ultrasound, because ultrasound can see not only anatomy, but also pathophysiology. And I would advise everybody of the youngest, go in your pathological institute and try to create a training setting in your own house. This works best, in my opinion.
Excellent advice. I completely agree with you. Maybe Professor Yoko Kato, you want to say something as a last word before we close?
Okay. Yes. Before the ASMI, maybe I thank you all the speakers. Maybe I think in the future, more and more less invasive the treatment is needed. I think because Japan is many of the senior the patients. I think then I realized the minimally invasive, such kind of the endoscopic surgery or some other minimally invasive treatment is quite a good result, I think. So patient can eat. That someone showed us a video. I think the younger generation need to know the knowledge and skills more and more. The viewpoint of the minimally invasive treatment. Maybe I think robotic or endoscope or so many things, including monitoring and maybe in the future the AI or medical DX, something like that. So maybe we should learn more from the expert, I think. Thank you very much for a nice lecture today. Asmi?
Thank you very much. I think as usual, everyone put their camera on, so we take a photo and document this. So Liu, maybe on your command.
Professor, Professor Benz have replied. He's in the panelist. He has emergency cases. Probably can ask him to say something.
Okay, Ben, please.
I would like to.
Press. Yeah, Benes.
Hello, everyone. I'm sorry.
Hello.
Oh, Benes. Hi, how are you?
Hello. Yoko, how are you?
You look very fine today.
Great to see you.
Very good.
I'm sorry for being late. I had an emergency case, but I would like to say one comment which I feel is important. I extremely enjoyed Professor Nakatomi's lecture, since what he has shown is that minimal invasivity does not mean the approach. Minimal invasive approach doesn't help, but minimal invasivity in relation to the lesion itself is the important part. We shouldn't be talking the approaches, whether it's approached by this approach and the craniotomy is 15 millimeter or 25 millimeter. That's not important. What's important is the lesion, and there we should be very much invasive as much as possible. And this is what we've seen with all the monitoring, with all the pre-op planning, etc. So this is probably the only message I would like to convey to all the participants. Thank you and apologies again for
Thank
being
you.
late.
Thank you for
Thank you so
joining
much.
us despite your very busy schedule, Professor Bernard.
So
Okay.
we're going to have a group photo. So
Yeah.
who is going to on the camera? I count until 10, then we snapshot 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, we screenshot now. Okay, thank you everyone.
Okay, thank you everyone. Have a good day till we see
Okay,
again.
thank you.
Thank you.
Thank you.
Thank
Thank you,
you.
Yasmin.
Bye-bye.
Thank you very much.
Bye-bye.
Bye-bye.
Thank you so
お疲れ様
much.
でした。